my lab, we do both T-cell receptor gene-modified cells. That's what I'm known for. And more recently, we've been doing CAR gene-modified cells. And they're very different types of cells. They function very differently. So with the T-cell receptor, you asked about solid tumors. We can treat solid tumors with T-cell receptor gene-modified cells. They have not worked as well as we would have liked, but there are plenty of examples of patients that have responded to T-cell receptor transduced cells, and now there's a push for neoantigen-based T-cell receptor targeting cells. And so I think in the T-cell receptor world, we need to, again, make the cells function better in the host environment. We've done some of that, and when we add cytokines, give cytokines to the patients or checkpoint blockers, we can see that the T cells actually get better in time. They become refractory, and then you can reinvigorate them, I guess, if you will. Maybe a vaccine could be part of that, and we're talking about those kinds of approaches. As far as CARs go, CARs have a reputation for not being able to get into solid tumors and not functioning well in solid tumors. And I think that is somewhat true. I think there needs to be a better understanding of a CAR T cell, because they function very well with hematologic malignancies, or they can. We also need to be aware of the targets, because many of the targets have led to self-reactivity, which have led to adverse events. Our CAR T cells, we have a CD19 CAR program, and we made cells in such a way that we don't see the cytokine release syndrome and other things and neurotoxicities that are seen with the other CD19 CAR cells. But it's just a first step. We need to understand better why we're not seeing these adverse events and others are, and we need to expand to other kinds of targets. So I think cell therapy is a role in this world and will for quite a while. But again, the key all comes back to getting these cells to function in a tumor-bearing host.